Hello everybody and welcome to our webinar, Eating Disorders in Nutrition Practice. I'm very excited to be here today and I'm joined with Emma, who I'm going to introduce on the next slide. Now, before we get going, I just wanted to get over some housekeeping. We will have some time at the end for questions, so please do add your questions into the chat box. And also, don't forget, DR.VEGAN, we have a fantastic practitioner scheme. If you're not already joined, do please sign up for that. You're going to get free products, discounts, commission, and a whole range of tools to support you in clinic. So the next webinar is on menopause in June, so do make sure that you sign up for that as well. Okay, so I'm your host. My name is Ella. I am the practitioner lead here at DR.VEGAN. And I have a passion for practitioner education, and I try to get the best experts on every month for our webinar so you can get down to the nitty-gritty details and really get to know deep knowledge about the subjects. So today I have with me our very special guest, Emma Dawson. So Emma is a registered nutritional therapist and has a very special interest in eating disorders and endometriosis. You might remember her from our endometriosis webinar. Emma, do you want to tell us a little bit about yourself?
Yes, so I've been working as a nutritionist for 12 years, 13 years maybe. Prior to that, I worked in and managed supported housing services and worked with vulnerable people in the community. Through my initial nutritional therapist work, became really passionate about supporting women with endometriosis and also with eating disorders. I'm currently doing my diploma in counselling, so I will be able to work as a counsellor with people with eating disorders.
Wow, that's all very interesting, and I'm certainly looking forward to this webinar. Okay, so today we're going to be looking at a few key areas. So understanding key eating disorders will be one of them, recognizing the signs in clinic, understanding the risks of eating disorders, how to know your scope and training and referral and scope of practice, understanding who is affected, how to navigate BMI and body size, when to know when to refer on and how to refer on, and also understanding the scope of practice in nutritional therapy. Okay, so Emma, without further ado, let's get going.
Great. So what are eating disorders? So we know that they are serious mental health conditions with physical, psychological, and social consequences. They're characterized by disturbances in eating behavior, restriction, binging, purging, and compulsive exercise are kind of four of the key components. Most eating disorders, not all eating disorders, are driven by body image, body shape, size, weight. They're all associated with marked distress around food, most of them with body image, shape, and control. So some people with eating disorders will be absolutely terrified of eating, and they will be spending the majority of their time thinking about the body shape and size and food. So it is potentially extremely frightening and unsafe. They're not defined by body size. They occur across all populations and all body types. Go on to the next slide. So Mortality and clinical risk. Eating disorders can be life-threatening without appropriate support. Out of all of the psychiatric disorders, anorexia nervosa has the highest mortality rate. It's around, so for somebody who is anorexic, they have 6 times more risk than somebody who doesn't have anorexia of mortality. And that is driven by both medical complications and suicide. So in terms of suicide, I think it's useful to understand for all of us NTs, and it's something that I learned fairly recently, that in terms of the physical risk of eating disorders, one of the risks is that if somebody has an eating disorder such as anorexia nervosa, they have an increased risk of suicide and suicide ideation. So that would be something for us as practitioners to consider with the work that we're doing. Bulimia nervosa is associated with serious medical complications, particularly cardiac risk, and it's estimated that for somebody with bulimia nervosa, they will have about 1.5 to 2 times more likelihood of mortality compared to somebody who doesn't have bulimia nervosa. As I explained, suicide risk is significantly increased with individuals with eating disorders. And something that we'll go on to speak about, severe complications can include refeeding syndrome and renal and liver impairment. Thank you. So I'll just repeat that. Who is affected? Who is most at risk? And what does the evidence tell us? So eating disorders affects all identities and backgrounds. We do have a kind of stereotypical vision of a teenage girl becoming developing an eating disorder, and that is definitely very, very real, but there are many other people who are affected by eating disorders. In the UK, it's currently estimated that 1.25 million people have diagnosed or undiagnosed eating disorder. Risk is highest in adolescents and young adults. There is also an increased risk when our body shapes change. So say, for example, for women, perimenopause and menopause, there is understood to be an increased risk of developing an eating disorder. There's often a big focus around eating disorders affecting women and those people who identify as female. Actually, at least 25%, so 1 in 4 people with an eating disorders are male. So it really does affect individuals across all identities. In terms of looking at different groups, LGBTQ plus individuals have a much higher increased risk of developing an eating disorder. So it's estimated 20% of LGBTQ plus young people versus 7% of non-LGBTQ plus individuals are likely to develop an eating disorder. And within the trans community, that's much higher. I think it's kind of like looking at between 40 and 50% of everybody who is trans at risk of developing an eating disorder. Awareness and research remain more limited in racially minoritized communities, and there's a lot of work being done to identify this at the moment. I think a big take home from that for me is that anybody who's sitting in a minority group is probably more at risk of developing an eating disorder, possibly because it's something that they can control when they're experiencing so much potential oppression and discrimination. And then in terms of neurodiversity, neurodivergent people are more likely to experience eating disorders. Within that, and of course everybody is individual, autism is more strongly associated with restrictive eating and ARFID, which we'll come on to look at. And ADHD is linked to binge eating. So the impulsivity and reward sensitivity attached to that. Sensory sensitivities may influence eating behaviours. Of course, that makes complete sense. So if somebody's sensory sensitivities are heightened, that will most likely affect their ability to eat food and enjoy it, because they might find it very stimulating. There is some excellent training via Lisa Smith and Benny Wright, who have the NED training on eating disorders within the kind of and neurodivergence. Thank you. Next slide. So types of eating disorders, I've put here just so you understand. So for somebody to get a formal diagnosis of an eating disorder, in the UK, we follow the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, which is published by the American Psychiatric Association, and provides standardized diagnostic criteria for mental health conditions, including eating disorders. So this will mean that if people don't necessarily fit a diagnosis of a formal eating disorder, they may definitely have an eating disorder or disordered eating, but won't necessarily get that diagnosis and potentially that support. So let's find out about the different eating disorders. So recognise eating disorder types. So partly in recognition of the fact that as humans, we are unlikely necessarily to fit into specific boxes. The most common recognised eating disorder is OFSED, which stands for Other Specified Feeding or Eating Disorders. And out of all of the diagnosed eating disorders, OFSED is the most common. And of course, because people may not meet the criteria for bulimia nervosa, maybe they go between bulimia nervosa and binge eating disorder, for example. And then the second most common eating disorder is binge eating disorder, and that's diagnosed where we see recurrent binge episodes with complete loss of control, but there is no purging, so there is no compensatory behaviour for the binging. Bulimia nervosa, that is a combination of binge eating and compensatory behaviours, including purging, fasting, and over exercise. And we'll talk a bit more about that in a sec. and then ARFID. So ARFID is the eating disorder that's not driven by weight or shape. This is the eating disorder that is linked to food sensitivities, not liking having the taste of certain foods or the texture, being scared of choking, as examples. And that is the eating disorder that's most linked to neurodivergence, specifically autism. And then anorexia nervosa and atypical anorexia. So anorexia nervosa is severe restriction of food, of calories, and intense fear of weight gain and body image disturbance. And then finally, and I'm listing the kind of key eating disorders here because there are others. Orthorexia. Orthorexia isn't currently seen as its own eating disorder that can be diagnosed in its own right, but it's fast growing, and orthorexia is around the unhealthy obsession with clean, healthy eating. And in terms of, as nutritional therapists, it's something that's really important for us to understand, that there's seen to be a risk for any restrictive diet increasing the risk of developing orthorexia. I've got some papers in the references that looked at the use of the FODMAP diet increasing the risk of developing eating disorders. So, of course, I'm not suggesting that as nutritional therapists we won't necessarily use restrictive diets, and of course certain diets such as being gluten-free if you're celiac are, you absolutely have to do that. And managing blood glucose, blood sugar, foods if you have type 1 diabetes, but it's around looking at when we use restrictive food protocols in practice that aren't necessarily 100% needed, if that makes sense. Great, so do you want to go on the next slide? So binge eating disorder. So if you're in clinic and you're not working with eating disorders and you're working with somebody who you start wondering whether they might have an eating disorder, if you see in their food diary or they talk to you about missing meals, especially earlier in the day, restriction and then binging cycles. So even though binge eaters aren't seen necessarily to restrict their food and then binge, in practice that's quite common for a binge eater. And some of the work that we would do as practitioners working with eating disorders would be looking at getting food in earlier and balancing the blood sugar levels. So chaotic and secretive eating in clinic, you're unlikely necessarily to see evidence of that. You might see the kind of guilt and shame. A client might talk to you about that in terms of when they're looking at their food diary with you. Depression, anxiety, and mood swings are maybe signs that indicate, well, any eating disorder, but specifically binge eating disorder in this moment. And then for the physical impact of binge eating disorder includes cardiovascular and metabolic risk because of the foods they're consuming at such high quantities, blood glucose dysregulation, insulin spikes, and fatigue, gastrointestinal distress, financial and social cost. Great. Do you want to go on? And then recognising bulimia nervosa in practice, and I think in your personal life as well. So dental erosion, somebody complaining about a sore throat or gastrointestinal symptoms. Some of those symptoms, as a practitioner, you might be thinking about, oh, does this person have reflux? Maybe it's not reflux, maybe they're intentionally purging. Hoarding or hiding foods, finding wrappers, so that's something that you might notice in your personal life. Frequent trips to the bathroom after meals. Secrecy around food. Anxious when other people are present. Low mood, anxiety, irritability and anger. And weight fluctuations despite apparently regular eating. Thank you. And then anorexia nervosa and atypical anorexia. So atypical anorexia, to explain, is equally as serious as anorexia nervosa, and it occurs when somebody is in healthy, in inverted commas, BMI or a larger BMI. So because that person hasn't hit the kind of what's seen as the dangerous weight, it might get picked up. So characteristics: severe restriction of energy intake, intense fear of gaining weight, rapid weight loss. So that could be somebody who's still in a larger body. Body image disturbance, rigid food rules, and excessive exercise. Physical signs could be cold extremities, fatigue, hair loss, loss of menstruation, low libido for kind of all genders, fainting, dizziness, constipation, delayed gastric emptying, gastritis as well could potentially be a sign there. Thank you. And then finally, in terms of the eating disorders, ARFID. ARFID stands for Avoidant Restrictive Food Intake Disorder. And this is the eating disorder that's not driven by weight or shape. It often begins in childhood, in young childhood, but it can persist into adulthood. It's driven by potentially low appetite, sensory sensitivity, or fear of consequences like choking or vomiting. And it can, as all eating disorders, lead to malnutrition and micronutrient deficiencies, low weight, fatigue, and GI symptoms. And then, of course, if it leads to malnutrition, if it leads to fatigue and GI symptoms, that will then make it harder for the child or adult to then eat more food, because there may be associating eating with increased GI symptoms. It's often associated with anxiety and neurodiversity. It's really important not to see it as picky eating. In practice, you would see a very, very limited food range, long-standing patterns, and a big impact on whether the person feels able to eat in a social setting. And in terms of an NT working with a client with ARFID, it may be that they simply ask them to have one pea, for example, if peas and green foods are fear foods, which they often are, to add one pea or one slice of cooked carrot to their food. And I think the other important thing with ARFID is making the person, the child or the adult, looking at how we can make them feel as safe as possible when they're eating. So being in a nice, safe environment for that person so they can relax. Thank you. So risks of eating disorders. We've gone through a lot of these. Just want to highlight refeeding syndrome. So after malnutrition, there is a risk that as electrolyte shifts, when somebody starts eating more food, there is a risk of cardiac arrest. So if you are working with somebody who's lost a huge amount of weight, who's malnourished and has been malnourished for a while, that requires medical monitoring before you can safely refeed. And that actually occurs in everybody, that not necessarily somebody with an eating disorder. And then in terms of cardiac risk in bulimia, that would be heightened because somebody's more likely to have electrolyte imbalances because of purging, for example. Clinical risks around suicide and self-harm I talked about earlier. So significantly elevated risk of suicide in eating disorders, especially if the client has a previous history of self-harm. So there's an awful lot to think about when we work with eating disorder clients. I would say that more and more people sadly are developing eating disorders, and the kind of client group and the community that supports people with eating disorders would really welcome other practitioners and people who are able to support. So going on to the next slide. So as a nutritional therapist, scope, recognition and referral. So eating disorders, as we've been discussing, may present in nutrition clinics, can occur in all body sizes and genders, may be hidden within health goals, and may be masked by therapeutic food protocols, and carry significant medical and psychological risk. And as nutritionists, we might be the first people that identify that somebody has an eating disorder, whether that's restriction or binging or purging. We might see really rigid food rules with somebody that we work with, and really heightened risk, fear of weight gain as examples. And so then taking it back to your supervisor, if you have clinical supervisor and you're not working with eating disorders or discussing it with a group, taking it to BAN, if you're a BAN member for advice, informing the GP are different things you might want to consider. So there is some excellent eating disorder training available for nutritionists. If you're a BANT registered nutritional therapist, BANT specifies currently I think there's two types of eating disorder training. And they also have additional requirements before you can work with eating disorders, and I will go through that a bit at the end. If you're AMP member, I contacted AMP to ask their requirements, and they said any practitioner working with active eating disorders should have undertaken relevant condition-specific training, be confident in recognising when multidisciplinary or specialist support is required. So they don't specify where you need to get the training, but they do specify that you do have the training. So specialist knowledge to work with eating disorders, understanding the different types of eating disorders, the risks associated with them, signs somebody may have an eating disorder, and the evidence base for supporting eating disorders. And I think for all of us, whether we work with eating disorders or not, it's really important to understand the importance of the language that we use with our clients. Clinical supervision, ongoing supervision when working with eating disorder presentations or working within a clinic, I think is really good practice. And being really clear of our scope of practice, recognising our limits. It's very important to work collaboratively if we're supporting eating disorder clients. So always informing their GP that we're working with the client, working alongside other roles within multidisciplinary teams, whether that's psychotherapists, psychologists, family support, doctors, etc. So moving on. So we are nearly at the end, and I wanted to have a little quick dive into body image and also look at BMI as well. So BMI in eating disorders. So there's positives and negatives, and I thought it was important because it's looked at, it's always kind of considered. So it's very useful as a screening tool to identify weight loss. It supports risk assessments. So the NHS would definitely be looking at BMI, and it tracks recovery. Limitations, I think, are multiple, and I'm sure in the future we'll see some different tool used either instead of BMI or alongside it. So eating disorders can occur in all BMIs. BMI does not assess behaviour or restriction. It doesn't account for difference between muscle mass, bone density, body fat. And I think specifically, it doesn't take into account differences in individual people. So somebody may sit naturally in a larger BMI, but that is the right kind of BMI, the right shape, weight for them. So then if that person significantly loses weight, but they still fit into a healthy BMI or even an overweight BMI, they won't necessarily be being picked up as having an eating disorder and needing that support. That are highlighted, so some quite recent papers have highlighted that BMIs were developed by looking at Caucasian men, and then I think maybe Caucasian women as well, and they don't take into account race, gender and age, because obviously BMIs change and body shapes change as we get older. BMIs are useful in terms of recovery targets. So evidence suggests that when somebody reaches a BMI of 20 to 21, that's often seen as the absolute minimum. There is a reduced risk of them returning to restrictive eating disorder. The higher the BMI for restrictive eaters who do go under healthy BMI. The higher the BMI, the lower relapse risk. So when somebody is kind of coasting BMI of around 19, they will be potentially more at risk of their eating disorder returning. And a kind of a clinical note here, eating disorder voice may be stronger at a lower BMI for that person, and may reduce their kind of capacity for weight restoration. Thank you. And then body image. So most eating disorders are about body image. And body image, just to be really clear, is the perception of your own body. Weight and body shape are common concerns, in the world we live in, as well as other aspects of appearance. So height, so for men, for example, there can be lots of pressure, or not even pressure is the wrong word, but there may be prejudice against men of different height. And then, of course, visible differences and disabilities. In terms of what we can do as practitioners, seek out diverse voices and balanced messages around bodies. Because we all grow up around biases, assumptions, and stereotypes, and we see that all of the time playing out in social media today. And I would really welcome you to reflect your own experiences and beliefs around body shape and size, and start to notice and challenge your assumptions around that. Some self-reflection questions to consider in your own time, just to start that process, is when did you first become aware of your body image? Like, how old were you? What messages did you receive about bodies, weight, shape and size, food and appearance when you were growing up? And how might those experiences influence your work with clients today? So that's kind of takeaway work from today, just to start thinking slightly differently. Thank you.
Thank you so much, Emma. That was a really great. Oh, there's more slides. Sorry, we haven't finished yet.
Really sorry. And I put this in blood glucose dysregulation and eating disorders. I just thought I'd put something practical in. This is something that we might think about quite a lot. It's pretty obvious from what I've talked about that eating disorders will impact blood glucose balance. And if somebody's restricting, as an example, for say binge eaters and bulimics, in fact all eating disorders, they'll have low blood glucose, strong hunger, they may binge, large insulin release, rapid glucose drop, cravings and further eating. And that cycle reinforces binge eating, increases food preoccupation, and food preoccupation can be a massive part of eating disorder picture, may worsen bulimia nervosa, worsens binge eating disorder. Thank you. So key take homes: eating disorders are common in nutrition practice. They occur in all BMIs and carry significant medical risk. Restriction worsens eating disorders. It may increase binge risk and reinforce disordered cycles. And nutritionists can make a real difference. Recognise signs early, avoid harm, support recovery, and refer. And then specialist and services and support. So Emma Hendricks runs one of the 2 eating disorder training programs that BAN asks for. The other place is National Centre for Eating Disorders, and they have a program that is for all practitioners, so it's not specifically nutrition. I think Emma's is currently the only one that is designed for nutritional therapists, and I would recommend that. And then Food and Body Peace is an excellent eating disorder clinic. I'm biased because I work for them, but it's led by Rachel Labour. Also, if you're looking for practitioner and eating disorder practitioner, you can go onto the BAN practitioner directory and search for eating disorders. And finally, Beat is one of the big UK eating disorder charities, and they're excellent.
Fabulous. Thank you so much, Emma. I've got some great references there. Okay, so I certainly learnt a lot, and I hope all of you who are watching this did as well. And it gives a really good starting place. So thank you very much for that, Emma. I really appreciate that. Okay, so before we move on, we're going to be having a look at some of the supplements that actually could be really effective to work alongside diet, lifestyle interventions in clients who have a history of eating disorders. So the first one we're going to be having a look at is the Daily Multi. So as you can see, it's pretty comprehensive. We've got plenty of vitamins and minerals in here. And I'm going to go through now a few of the vitamins and minerals and explain why specifically they're necessary for people with eating disorders or history of eating disorders. Okay, so vitamin A. So people with eating disorders are actually at more of an increased risk of vitamin A deficiency. And that's generally due to inadequate dietary fat intake, malabsorption, or highly restrictive food choices. Vitamin A is obviously important for things like the immune system, skin, mucosal integrity, vision, tissue repair during nutritional rehabilitation as well. So that is something that you do need to think about. It's not just kind of supporting that client, their nutrient deficiencies. Is about supporting the body to recover from, very restrictive eating. We also have on here vitamin C as well. So vitamin C is actually often inadequate in individuals who have restrictive eating patterns, particularly when fruit and vegetable intake is low. Deficiency can impair immune function, wound healing, collagen synthesis, and iron absorption. And of course, all of these are important for recovery and physical restoration. Okay, next we have vitamin D. And interestingly, vitamin D status was frequently extremely low in individuals with eating disorders. And it was especially low in those who had low body fat, limited dietary intake, and reduced sun exposure. And of course, vitamin D is essential for immune regulation, mood support, and bone health. So that they're really, really important for overall health. So just make sure that you are testing your clients and making sure they're on an appropriate vitamin D supplement, or at least having a maintenance dose in a multi. We also have vitamin E here as well. So vitamin E protects cells from oxidative stress and inflammation. And so stress and inflammation is often elevated in people with chronic malnutrition and in periods of psychological stress. And individuals with fat malabsorption or very low fat dietary intake are at greater risk of deficiency. And deficiency can affect things like neurological health, skin health, and immune health. We also have here vitamin K, so specifically vitamin K2. Again, because it's a fat-soluble vitamin, people with eating disorders are at increased risk of vitamin K deficiency, and deficiency can lead to poor bone mineral density, inadequate nutrient intake can also lead to things like hormonal disruption, low body weight as well. Supports calcium utilization, bone mineralization, and also helps get the calcium into the bones as well. We've also have vitamin B1, also known as thiamine, and deficiency is particularly important for those with eating disorders, and that's because prolonged restriction of food, vomiting, or laxative misuse, or refeeding actually as well can rapidly deplete stores. Severe deficiency may contribute towards fatigue, neurological dysfunction, impaired cardiac function, and in serious cases, sorry, I can't say it effectively, Wernicke's encephalopathy during refeeding. That's a bit of a mouthful, that word, isn't it? Okay, so we also have vitamin B2 as well, so that's known as riboflavin. That supports energy production and cellular metabolism, and both of these are impaired in malnutrition. So low riboflavin levels, they do contribute towards fatigue, poor skin integrity, mouth sores, and reduced antioxidant capacity. Okay, we skipped a few there by accident. Okay, so vitamin B12. Okay, so deficiency is actually more common in people avoiding animal products or consuming highly restrictive diets. So it is easily testable. So do make sure they are having that tested on their by their GP on their blood test. So poor levels, of course, everybody knows it contributes towards things like anemia, fatigue, also cognitive impairment, numbness, poor concentration, and also other neurological symptoms. So it's really important to get the vitamin B up effectively, and actually, if necessary, you can request the vitamin B12 injection from the GP. Okay, so vitamin B3, so also known as niacin, it is essential for cellular energy production and nervous system health. And inadequate intake may worsen fatigue, cognitive difficulties, low mood, and poor concentration. And these are all common in those with eating disorders. We've also got vitamin B5 in there, which is pantothenic acid. And pantothenic acid supports adrenal hormone production, energy production as well. And both of those can become dysregulated in states of chronic stress and undernutrition. Excuse me. And poor intake, can lead to things like poor energy. So when you support that intake of B5, it can lead to energy restoration and nervous system health. Excuse me, I've got a tickly cough there. Okay, so vitamin B6, also known as peroxidine. It is involved in neurotransmitter synthesis, including things like serotonin, dopamine, and also linked to mood and anxiety, and also appetite regulation as well. So deficiencies can contribute to things like low mood, irritability, immune dysfunction, and impaired protein metabolism. So definitely something you want to make sure they're getting enough of. Folate. So folate deficiency, again, is common in individuals with inadequate dietary intake. And, folate is quite high in green leafy vegetables. So if it's an eating disorder that prohibits or is really difficult for someone to consume green leafies, then folate deficiency may be a significant problem. Can lead to things like, fatigue, anemia, and also low moods. So folate is essential for DNA synthesis and tissue regeneration as well, especially during things like nutritional rehabilitation. Calcium, again, really important. Low intake, can cause significant problems. So for an example would be weak bones, poor hormone, poor digestion. So it's really important to make sure that they are consuming enough calcium to help reduce the risk of fractures. So people with eating disorders generally do have a higher risk of poor bone health. So do make sure that you are supporting their bone health properly. Chromium as well, that supports blood glucose regulation and insulin sensitivity. Again, really, really important. As Emma mentioned earlier, blood sugar balance is really important to help with some type of eating disorders. So do make sure that they are getting enough chromium in there. And also it's particularly important during refeeding when blood sugar fluctuations may occur. Okay, so let's have a look at iodine. Again, intake may be impaired, and it can affect things like hormone production, energy production, may cause metabolic slowing as well. So this is quite common in those with eating disorders, and it's an adaptive response of the body. So it's really important to make sure that the iodine is adequate to help regain metabolism and energy production. We also have iron on here. So iron, again, is another really common deficiency in those with eating disorders. Again, one, really make sure that you're checking the blood work properly to make sure that they do have enough iron. And this is something you can easily work with the GP on to request, frequent blood tests for iron as you go through your journey together. Okay, magnesium. Again, depletion can occur due to inadequate intake, but also things like vomiting, diarrhea, and also laxative misuse as well. So low magnesium can contribute things like muscle cramps, fatigue, anxiety, and also sleep disturbances as well. We've got manganese as well. So manganese, again, it's a really important trace mineral and really important for things like bone health and healing. Again, going back to bone health, it is essential that we are giving them all the nutrition necessary to protect their bone health later on in life. Okay, so we've got selenium. Again, essential for thyroid function. It is an antioxidant and does contribute towards glutathione peroxidase production. And it's particularly important during recovery because it does help support that thyroid function, get it going again. And it is often depleted in those with prolonged malnutrition or undernutrition. We have selenium on here as well, and selenium is a really rich nutritional powder. It contains many things like proteins, iron, antioxidants, micronutrients as well. And although it doesn't replace, a healthy balanced diet, it's just an extra additional support that's in this nutritional formula to aid with recovery. Okay, then we have turmeric. So turmeric, again, is anti-inflammatory. Inflammation can be elevated in people going through periods of psychological distress. So it's also antioxidant as well, and also supports things like neurological health during recovery and healing. Okay, and zinc also is a very common deficiency symptoms. Make sure you're checking their nails for the white marks. Make sure you're looking at other signs of zinc deficiencies as well. It can lead to things like poor appetite, altered taste perception, as well as things like impaired immunity, hair loss, and low mood. And it's essential for gastrointestinal repair as well. So really important to get that in there. Supports, as mentioned earlier, supports appetite regulation. So make sure that they are having enough zinc. Okay, and we've got biotin. Again, so biotin deficiency can occur with restrictive diets and contribute towards things like hair thinning and brittle nails. And molybdenum, again, it's one of those trace minerals, and it is required for the activity of enzymes. It's involved in sulfur amino acid metabolism, detoxification, and the breakdown of certain medications and metabolic byproducts. So in people with eating disorders, prolonged dietary restriction and inadequate nutrition intake may compromise molybdenum-dependent enzyme function, potentially affecting energy metabolism, neurological health, and cellular detoxification during recovery and refeeding. Okay, so we've got boron next. So boron does also help to support bone health and mineral metabolism, and also with hormones as well, can help to balance hormones. So really important to give people who you are concerned about their bones, if they've had a history of eating disorders, they currently have an eating disorder, make sure you are getting the nutrition in there to support their bones and protect them from future bone issues. So boron supports the utilization of calcium, magnesium, and vitamin D as well. And finally, we've got choline, again, which is really important for liver function, brain health, and also fat metabolism. So choline status can become impaired in those with eating disorders, and it is needed when you're kind of refeeding when somebody's recovering from an eating disorder. So the fact that it supports brain function and neurological health, again, really, really important for people that have or have previously had an eating disorder. Okay, so that comes to the end of the slides here. We're going to take a few questions. So Emma, okay, so first question for you here. So if you are a nutritional professional and you feel like sometimes you might be very picky yourself or very, very overly strict with what you're eating yourself, and you are a bit concerned, you know, you've listened to this webinar, you're thinking maybe I'm kind of a bit over restricted with myself, with my eating, maybe maybe I have a potential problem. What would you then suggest would be the first thing for people listening to this webinar to do for themselves? Oh, I think you're on silent, Emma.
Sorry, I silenced myself when you were presenting and I forgot. That's a really good question. It's a really, really deep question. I think, and it's a question I think it's really important for all of us as practitioners, because we focus on food, we focus on nutrition as our jobs. We do so much training around food and nutrition. And we think about it so much. I think there probably is an increased risk for NTs to develop, say, maybe orthorexia potentially. I don't know whether there's any research on that, but it would make sense. I think it's with eating disorders, it's very much linked to what does that eating disorder give us? How does it benefit us? Because it is part of somebody's coping mechanisms. And there's a lot of association with lack of kind of confidence, lack of self-worth. I would recommend that if you are concerned that you may have a eating disorder or disordered eating, the charity Beat is really good. They offer a lot of support there. It's definitely worth checking in and seeing what services they provide. If you've got a nutrition community that you exist in, that you're a member of, that you can get some support from, speaking to them. I think with food preoccupation and with body shape and size preoccupation, it's thinking about how much percentage of my time do I spend kind of worrying about food, what I'm next going to eat, what I don't want to eat, what my body shape looks like, what size I am, how much I weigh. And if it's becoming quite a large section of your time, then it would be something to consider getting support from. But that's really, really general. I think if you've got any concern at all, I would seek professional support first and foremost. Is that okay?
Brilliant, that's great advice. Thank you, Emma. Okay, so we have another question here as well. So so if somebody is interested in working with eating disorders, where do they start with this?
So Emma Hendricks, who I mentioned earlier, runs, I don't know whether they're annual or biannual, I think they're annual groups. So she's got an eating disorder for nutritional therapist program that she runs. I'm actually on that program at the moment myself, and I would highly recommend having a look. National Centre for Eating Disorders as I think I said before, runs a separate course. I actually did that training a few years ago. That training is for any practitioner who works with eating disorders. So when you do the training, you'll be kind of remotely sitting alongside psychologists, psychiatrists, doctors, nurses. So it's not going to be, you're not going to be learning about how to support people from a nutritionist role, but a general role. But it's also very good. They are the two that I would recommend. If you're BANT registered practitioner, they have a whole section on eating disorders and what is required to work with eating disorders as a BANT practitioner. And ANP don't have specific expectations for their members, but they do expect their members to have adequate, significant training in eating disorders.
Fabulous. Thank you so much for that, Emma. And if anybody has any questions later on down the line, or maybe you're watching this on demand, please do email me. My email address is right there on the screen, ella@DR.vegan.com. And do join us for the next webinar on menopause. And don't forget to join up to the practitioner scheme and go to the Doctor Professionals website and check out all of the resources we have available to you on there. So thank you so much, Emma.
Thank you.
It's been a great one, and I'm sure everybody has enjoyed it.
Thank you very much.